I became interested in using lasers in the treatment of periodontal disease about 6 years ago. I was at a local convention where a number of my colleagues, specialists in periodontics, were attending, as was I. And throughout the time that we were there, learning other things, I had conversations with 3 of these people at different times, not coordinated one with another, and each of them was saying that they had stumbled into essentially using the dental laser and how effective it was at cleaning up and taking care of gum problems in their practices, and that I would be smart to look into it. So I did. On their recommendation, I enrolled in coursework and purchased a laser, and it took a year of training at different times while I'm still practicing, of course. But I went to New York for a couple of visits, and I went to LA for a few visits throughout that time to become competent in the use of the protocol for treating periodontal disease using a dental laser. And I will share with you at the end here a number of patients that I have recently gotten the results back on, having gone through the laser protocol, and we'll explain it. Prior to that, I gotta give you a little more background so that you understand what we're talking about when we talk about the results. First off, a laser is electromagnetic energy. Prior to this, in the treatment of periodontal disease, we've used mechanical and chemical. Chemical, mouthwashes, antibiotics, mechanical, cleaning roots, and doing surgical procedures, removing gums or pushing gums away and treating something and then stitching them back. Those are all mechanical activities, and they're used with a laser as well. It's that we're adding a laser protocol to this, which actually changes the whole dynamic of how we treat. For example, classic treatment of periodontal disease begins with the scaling and root planing of roots, and that is once a diagnosis is made that the pockets are greater than a 3 millimeter, then it allows us, the protocol for treatment of pockets that are deeper than a 3 is that we can use scaling and root planing. Scaling and root planing is scaling off the calculus or the tartar that's been formed because of the bacterial colonies attaching to the roots and then crystallizing or mineralizing. And so we clean those off. So we scale that off and we plane the roots smooth in order to remove any toxins off the roots so that it allows the tissues to grow back. And that is a normal protocol, and we can anticipate up to a 2 millimeter change in the pocket depth. So if there's a 4, it could go to a 2. If it's a 5, it could go to a 3. Those are within the ranges of what we would anticipate. Could we get more or less? Yeah, but that's what we would anticipate. That's the general response of scaling and root planing. If you have a 9 millimeter pocket, you can anticipate up to a 2 millimeter change. You still have a 7 millimeter pocket, which is an advanced site, meaning that organisms that do not utilize oxygen can be living down there, anaerobic organisms that are very toxic and very aggressive and detrimental to your general health. And that's why we have all of this interest today in the combination or the connection between periodontal disease and general physical conditions that people have, heart disease and others. So these are types of organisms we do not want in the body, and consequently an advanced site, which is I consider a 6 millimeter pocket or greater, when somebody is in supportive care, they've graduated through the active treatment and the use of the laser and all that, and they're now in supportive care, coming at intervals of care to monitor and to clean areas they still can't reach by brushing and flossing, because they still probably have something that's greater than a 3 millimeter pocket. We don't want to have anything that's an advanced site to maintain these folks. Okay, so the two numbers, and I say this on another video that's called A Tooth Has 4 Parts, which is really part of what I have every patient that I treat see. You can see it on my website on the front page, and it's 15 minutes long, and it explains how patients are managed if they have a diagnosis or a history of a diagnosis of periodontal disease, and how they're different than other patients and what we do. So it kind of helps people understand, why am I going to somebody and what are they going to do? And it helps them kind of track how they're doing and what their care is like. So, but the change that the laser provides is that I can use it at an early stage or a late stage, all combined into one procedure. I don't have to go through a scaling and root planing phase and then do another examination, and then from that examination determine that, oh, we still have deeper pockets and surgery would be useful, so we now do the surgery. And now part of the objective of that surgery is to continue to shrink those pockets, and so make them smaller. And a lot of that is recontouring the tissues, both bone and soft tissues, in order to enable somebody to clean with different cleansing brushes and things like this. So that being the normal protocol. You can imagine that there are a number of visits, and you have to go through this whole process until you graduate into going into maintenance or supportive care. With a laser, however, you can do it all up front and essentially eradicate all of the organisms, because that photo energy kills the organisms that are in the pocket. And then with a second pass of this particular laser, called an ND-YAG laser, it will go in and warm the blood in those deeper pockets to seal off those areas, and then the bacteria don't get down in there while we're waiting for the tissues to get healthy. And in fact, the laser energies are also biostimulating, meaning that they can actually turn on other cells that are actually healthy and stimulate them to actually grow and multiply and do good things. So it's not just that you use the laser in a, quote, destructive mode of destroying organisms and cleaning up a mess, but you're also stimulating the cells in the surrounding areas to actually turn on and begin to do the healing processes at a little quicker clip. And so all of that's beneficial for enabling the patient to get through this process. So you do this procedure I do it in one visit. People, if they have full mouth periodontal problems, they leave very numb. But in a few hours, that anesthetic's gone, and they're feeling their lips and tongue again. And they're not really noticing that they're having a great deal of pain from the procedure. In other words, the gums feel a little bit tender because I've worked them over a little bit, but not a lot of pain. This laser actually, in some ways, reduces pain, and so because it's biostimulatory, so it can calm nerves. But the net result is that it's kind of like they've had a thorough cleaning, and so they're recovering from that. But much less than toothaches or extractions or surgeries of any sort. They're much more comfortable. And and they only go through it once. And the reason to go through it once, not only does it eradicate all the bacteria at one time, which is a good thing, so we're not having organisms from one side of the mouth cross over and reestablish themselves. We essentially eradicate, especially the anaerobic organisms. So that's a good thing. But they're going to be on a liquid diet for 3 days, my recommendation. So they're not stimulating the gums and moving them around at a time where we're getting early formation of the clot. So people are on a liquid diet, and they're not brushing and flossing because, again, we're using a chemical control, which I said we use mechanical and chemical. We're using a chemical control, which is an antibiotic and a mouthwash to keep the plaque levels, the bacteria levels down while everything is healing. And so you're not banging around the gums. After about 10 days, we go back to normal routine. And from that point on, then it's a matter of monitoring and avoiding probing in the areas that would then open it up because I mechanically open them up. And we wait to about 6 months or after before we ever get the measurements. So the things I'm going to show you, the reports that I have on these patients are 6 months later, and this is the second time that we've measured. And so I'm going to tell you what has happened with some of these patients, just to give you an idea, now that you know about advanced sites and things. So we'll work through this. The first patient was 55, a male, and he was comfortable at the time. And what I'm reading to you are the things I'm pulling out of a report that I would send to their dentist if they have a dentist. If they don't, it's going into my reports, but generally they've been referred. Some have not, but many have. So what I'm saying there is they're comfortable. There's no, let's see, he states the sensitivity lower right is reduced but not disappeared. So he still has some issue. And the bleeding index has gone to 27%. Now I'd like it at 20%, but they don't have to be at 20%. They need to be going toward 20% and less. And if it takes a little bit of time, that's okay. But where did they start? Well, it's down 26 points. So they were up in the 50 percentile, and now they're down at 27%. So that's a good reduction. Now, advanced sites. This individual had 22 advanced sites at the completion, but they dropped 24 advanced sites. But we go further. 18 sites improved by the 2 millimeters. 11 sites improved by 3 millimeters. 10 sites improved by 4 millimeters. 5 sites improved by 5 millimeters. 1 site improved by 6 millimeters. 1 site improved by 7 millimeters. And on that one, I've said it's tooth number 32. That's a wisdom tooth. 2 sites improved by 8 millimeters. Those were on a bicuspid. And 1 site improved by 9 millimeters, and they were on that bicuspid. So there was 1 bicuspid that responded extremely well. And now we go on. 1 site worsened by 2 millimeters. 1 site worsened by 3 millimeters, and 1 site worsened by 5 millimeters. All of those are wisdom teeth. Okay? So what do we get from all of that? Well, aside from wisdom teeth, the responses were excellent. And my recommendation to the individual is referral to oral maxillofacial surgery to extract the 2 wisdom teeth that were not responding. So even though under the wisdom teeth we had some probing depths that were changed, maybe they improved, but right next to them, if something's worse or the same, the tooth's still in the same situation. So bottom line was the laser didn't really help the wisdom teeth at all. All right, we'll move to another one. This is a 68-year-old male, and he's comfortable and has not had any problems during the 6 months since the procedure was accomplished. His bleeding index is 16%, so he's dropped below the 20%. He's down 34 points. Okay, so what is that? That's 50 points, 50%. Was his bleeding. Half of the sites probed were bleeding before, and now he's at 16%, which is good. Advanced sites, he has 2, meaning they're 6s or something. He's down 14 sites. 17 sites improved by 2 millimeters. 7 sites improved by 3 millimeters. 2 sites improved by 4 millimeters. 2 sites improved by 5 millimeters. And that's it. Nothing got worse. Everything was the same. Now remember that most of the time, most of the pockets in anybody are going to be at the 2, 4, maybe 5, 2 to 3 actually. And the 4s and 5s and beyond are more focused where things have broken down in general. And so those are the only ones that have the opportunity to improve by like 5 millimeters. That wouldn't happen with a 3 millimeter pocket. So the population that could improve is less when you get to these deeper sites. So that's something to keep in mind. And on him, I guess there was one other thing on the other next page. Says surgical flap to reflect in 2 areas, just to visualize why these things didn't improve as much. Those were the 2 that were the advanced sites that remained. So what do we get from this? Well, the laser dramatically improved everything. There were a few spots where I'm still saying, maybe there's something about these areas where the laser alone, because we've done it in a sort of a closed approach, we haven't looked at it. Maybe I need a little surgical reflection to see what's going on and correct some problem. So again, you use for people what is necessary to get them to a point of good stability and being able to manage keeping the teeth long term. That's the objective. All right, next patient, 52-year-old male. His bleeding index at the conclusion of 6 months was 20%, so he hit the mark, down 33 points. His advanced sites, he had 1, down 10 sites. 5 sites improved by 20 sites improved by 2 millimeters. 5 sites improved by 3 millimeters. 2 sites improved by 4 millimeters. 1 site improved by 5 millimeters. And 1 site improved by 6 millimeters. And I have parentheses, but that started as a 12 millimeter pocket. So a 12 millimeter pocket now probes at 6 millimeters. So the recommendation at this point would be we could go back in and see if we can get more out of that 6 millimeter by repeating the laser, but let's make sure for a little while that it's a stable, everything is stable. And I will say this as an aside, most of these folks as we go forward, they don't break down again. They're not like 3 to 6 months later I measure again and oh well, they're all back. No, they're gone. That's the common, that's the normal. Now with this 6 millimeter, that was a 12, what could happen? Well, it could open up some more, or it could stay as it is, or it could get better slowly with a little bit of time. Let's get some more numbers on this one. Everything is doing well, so we'll put them into maintenance for a little bit of time, get some more data, and then make a determination as to what we want to do for this particular advanced site, because again, we don't want advanced sites. All right, next one, 54-year-old male. He's comfortable, no concerns, problems. The charting, bleeding index, 32%, down 7 points. That wasn't very much. It was starting a little lower than the other bleeding index, but that's okay. All right, so advanced sites, none. He has no advanced sites, down 58 sites. 52 sites improved by 2 millimeters. 40 sites improved by 3 millimeters. 15 sites improved by 4 millimeters. 8 sites improved by 5 millimeters. 2 sites improved by 6 millimeters. And we recommend the supportive care at a 3-month interval, and we'll check again in 6 months, see how he's doing. He's locating a dentist and when he finds a dentist, I'll transmit all my notes to that individual, and we'll continue to care. And we did a cleaning at the end of that appointment. That's the interesting thing about this is his bleeding index is still a little high. Well, what is that? Well, that's a gingivitis. If the person's not cleaning that well, it still indicates it, or actually in a better way, it indicates that the laser effect and the type of therapy that he received had a profound impact, and he's not holding up or able to do as much for himself as maybe somebody else. So even in spite of that, we've gotten good response. I still would worry long term if somebody's not able to clean well, but that then has us modifying the intervals of care so we make sure that the patient's doing okay long term. Okay, so what else? All right, let's do one more. I'll do 2 more. Females. This is a 44-year-old. So bleeding index 20%, up 2 points. That's interesting. Advanced sites 3, down 14. Let's see, 18 sites improved by 2 millimeters, 7 sites improved by 3 millimeters, 3 sites improved by 4 millimeters, 1 site improved by 5 millimeters. So We could retreat advanced sites with the Nd:YAG, the laser, but a 3-month interval, and continue to monitor. And so bottom line is we don't have to rush to things. We can take a look at them and see what we want to do. All right, last one. 56-year-old female. Bleeding index is 28%, but it's down 35 points. Advanced sites 2, down 26. Both are associated with one tooth, which is an upper bicuspid. 14 sites improved by 2 millimeters, 10 sites improved by 3 millimeters, 3 sites improved by 5 millimeters, 1 site improved by 6 millimeters. We're going to do an alternate care with the other dentist, and we'll continue to monitor this one tooth, and it may not remain long-term a problem, and it might benefit or not. Let's see, what have I said? It might be beneficial to consider selective retreatment on the one tooth. So we'll see. It may improve. My point is it may improve. Let's monitor it. We can do that for a little while. We still don't like advanced sites. So that's it. I think my finding is, do you get 6 millimeter changes with surgical procedures? Yeah, you can, but you're reducing the pocket in a different way by reducing tissues and kind of opening up areas. Whereas with the laser, you're doing it from the bottom, meaning down at the base of the pocket up. And so in some ways, the one remark that a lot of people have made is that the way it looks aesthetically with the gum levels on teeth, it's not as much loss as with other kinds of procedures. But I don't want to knock, I'm not going to knock any of these procedures. They work well, and we have other surgical procedures that actually can increase gums and change positions and all of that. So it's not like this is a terrible response. Conventional care, bottom line is conventional care works, but it's going to be more procedures, more time in the office, up to the point of getting to the supportive care than it is with the laser. And the final thing on the cost of this, we're able to modify the kinds of codes we use. There is no laser code in dentistry because it's essentially a tool that we use. It would be the same as saying I used a scalpel code or I used a suture code. I did a procedure and these are the steps I used to take it. If I choose to use a laser or not, it's the code of the procedure in general that we're using and that we submit to insurance companies. Some insurance companies are looking for every excuse they can come up with not to provide to pay off, and they'll look for things that might say, oh, it's a laser, because their dental people who are reviewing it are skeptical on the use of laser, as was I. I'm not arguing that. This is the way technology works. It begins with a small group of people and it slowly grows as it's adapted by more and more users. And like myself, I didn't jump into lasers until I was hearing from others that they had found good responses too. So it wasn't just an experimental thing that I'm looking for any opportunity to do something new and wild. I'm looking for things that really have an impact and improve patient care, and this turns out to be one of those. So that's it. The costs are much less, can be much less. Now, depending on how other people code them out, that's variable. But I am trying to do this as effectively as possible, and because it's lowering my chair time with patients, it doesn't cost me as much to have them coming back and forth all the time. So costs are less, and that's a good pass through. So if you have any questions or you have comments or whatever, please let me know and pass this on to others who might be interested in seeing it. Obviously, this is a very specialized kind of discussion, and it's not a general view, popular kind of video that I'm expecting to get millions of likes on. I don't really want that. I'd rather have it get to the right people who need to have this information. So if you can help by passing it on or encouraging others to look at that or look at my website and the other videos, by all means do that. It would really help. All right, thanks a lot. Have a great day.